Hey folks, I'm Dr. Nima Shahi and this is Eyes and Body. In this first episode, I have the honor and pleasure of having Dr. David Lederer here. Dr. Lederer is what I consider a true expert when it comes to diseases of the retina, such as age-related macular degeneration and diabetic retinopathy. He was a great mentor to me during residency, and we've kept in touch over the years, and I've learned a lot from him. So I'm really appreciative of the fact that he's put in the time to sit with me today so we can discuss one of the most common diseases in our field, age-related macular degeneration. So David, welcome. Thank you for being here. Can you tell us a little bit about your training, your practice, a little bit about your background?
Yeah, absolutely. Thank you for having me. It's generous of you to discuss my influence on you. I think you've probably at this point standing on your own 2 feet, so I probably have a lot to learn now. But let's see. So for my background, I went to school at Tufts in Boston for my medical school, and then I went up to McGill. Went up north. I'm originally from the States, so that was a fun experience for me. And I did my residency at McGill in ophthalmology. And then after that, I went on to do fellowship training, specifically in medical retina diseases, and I went down to Duke University to do that. Really an enjoyable time. And then met my wife somewhere along the way and ended up back in Montreal where I'm practicing happily now.
Okay, great. And so we crossed paths when I was a resident at McGill, and you were a junior attending, but we're really impressed by your methods and practices and how much you were able to teach while you were taking care of patients. And really at the time, I think it was some of the early days of intravitreal injections, the injections that we give for diseases like macular degeneration. And it was really impressive the kind of results we were getting at that point after, I guess, decades of not having good treatments, right?
Yeah, no, for sure. It was the fun early days. I got involved with medical retina, and by the time I was involved, intravitreal injections were already ongoing. So I wasn't quite at the front wave of it. But I do remember that when they were initially released within the field, that one of the very first meetings that they came out at was actually the ASRS, or the American Society of Retina Specialists meeting in Montreal.
Oh, wow.
And I happened to be there. And a lot of the other senior attendings were very aware as to what was going on. I was still in residency at that point. But I realized years later that was really the initial aspect of the wave going forward for macular degeneration and a lot of different retinal vascular and choroidal vascular diseases. So I saw the wave vicariously as a resident and then got involved as an attending as well.
Yeah, well, you had great judgment, so because we've come a long way, as you know, in treating this disease. But this channel, David, is for patients. So let's start with the basics. What is age-related macular degeneration, or AMD?
Yeah, so age-related macular degeneration is a very common disease that we're going to come across in clinic. And of course, there's many different ways to define it and look at it. But I think one of the key aspects for patients to understand is really making sure that there's a common vocabulary to discuss it. So when I first meet somebody, I kind of try and take a quick pulse as to what they know about the eye. So obviously a little bit of anatomy is very important for the patients to understand. And the age-related macular degeneration is really a disease that affects the nerves for center vision. The retina has a small area in the middle called the macula, and those are the nerves for center vision. And age-related macular degeneration is a disease that affects those nerves right in the center. It's commonly associated with things like aging, genetics. There's environmental factors for sure, and then there's probably a little bit of chance. You can have 2 siblings that both might be older and not get the disease, and might not get the disease equally. One might get one might not. So there's a lot of things that go into play at it. But very roughly speaking, before I digress too far, it's a disease that affects the macula, and those are the nerves for center vision. And I think it's really important for patients to try and at least understand a little bit of eye anatomy,
Yeah.
to be able to go through disease aspects.
Yeah. So actually, David, in the very first episode, I went through a bit of eye anatomy, so I tried to show where the macula is.
Nice. So I don't have to.
So that people understand what we're talking about here. So, and you actually covered one of my other questions, which was what causes age-related macular degeneration. And you mentioned genetics. So one question that comes up a lot is this genetic, or do I have to worry about my kids getting this, right?
Yeah, no, for sure. It's a very common question. And yes, the factors that cause AMD, or age-related macular degeneration, are quite varied. And there is a huge genetic component, but it's not always one-to-one, meaning just because the parents had it doesn't mean the kids get it in the next generation, etc. Mm-hmm. And that's because the genetics is actually rather complicated. Mm-hmm. There's a lot of genes that have been identified as etiologic or causative for macular degeneration, but they seem to occur in varying combinations that we still have a lot to learn about before we can really provide a genetic treatment or cure. So we know that genetics is huge. Age is very important because we get these degenerative changes as we age, mostly just because our body has less of an ability to heal. Right. With time. And then environment seems to play a huge role. Some of the environment might be things beyond our control, where we live, a lot of sun exposure, as an example. But other aspects are well within our control. Things like smoking, eating habits. Mm-hmm. And all of those things seem to play quite a role. And as we're talking about genetics, we do know that there's a racial predominance, more for people of pale skin as opposed to people of darker skin. Although in truth, you can get AMD in people that are darker skin when there's a strong enough genetic component, but statistically speaking, you're more likely to see it in the Caucasian race.
Right, perfect. All right, so let's talk about a little bit about the different types of age-related macular degeneration. So we often hear about the wet type and the dry type, and the patients want to know what the difference is, and in terms of treatment, how the treatment differs, what's the progression of one versus the other. Can you speak to that aspect of it a little bit?
Yeah, for sure. It's a huge area of discussion, as you very well know, because we generally classify on the initial discussion with patients into this idea of dry and wet. And it's really one as opposed to the other. So in wet AMD, you get blood vessels growing, leaking, and bleeding where they shouldn't be, that cause a lot more damage much more quickly to the nerves. And dry AMD is really an as opposed to wet, meaning you're not having those blood vessels there, but you still have the hallmarks of macular degeneration. So what are the hallmarks of macular degeneration that we see? It's things like pigmentary changes or change in the color of the nerves, and accumulation of drusen, which are these yellowish protein fatty materials that accumulate under the nerves responsible for vision. And people that get that are then really able to be classified or defined as AMD, meaning when we look inside of the eye, we see characteristic features that in the right patient population help us define the disease. It's a very visual specialty, right? Yeah. Most of our things that we say are defined by how they appear to us, meaning it's not a blood test that determines AMD. So as we go into that classification system, there's obviously a concept to it that the disease is a giant spectrum of pathology. So you can have a little bit of dry and stay dry for your whole life. Or you can have a little bit of dry that progresses to more advanced stages of dry. And you can have dry that progresses to wet. But I would say one of the most confusing for one of the most confusing aspects for people to really wrap their heads around is that these are not necessarily mutually exclusive. So you can have wet disease with dry disease still underneath progressing. And I find that's important for people to recognize. And additionally, the eyes can be independent. So you can have one eye dry, one eye wet. Maybe in your wet eye, you've still got the dry going on in the background. So it's fairly complicated in terms of thinking about it, and it's certainly a large spectrum.
Now, I'm going to ask you something that kind of strikes me occasionally when a patient asks me once they're diagnosed with AMD. They say, Doc, am I going to go blind? So what do you say to that? I'm sure you've heard that question.
Yeah, for sure. It's a very common question, and I completely understand it. I mean, if I were a patient, that would be the thing that I would be most worried about. And the way I like to explain is it's really never lights out blind. It's never can't see anything. I tell people that they'll never need somebody to feed them, dress them, or walk them around because of their eyes. Their vision can get blurry in the middle. It can be harder to read and watch TV and see face details, but I always try and reassure them that they're never completely blind. And I actually find that even just that one simple statement really provides a lot of relief to their anxiety. I would say, as long as we're in this kind of forum where we're talking about it, that in all fairness, there are multiple ways to define blindness. And usually I find when patients are talking to me, that's what they're referring to as lights out, can't see anything. But there's other aspects that can be important to people over time. Driving vision. You could lose driving vision if your vision is blurry enough, but not be lights out blind, because there's specific driving criteria that are set up by the government and the police to help provide road safety. The other thing about blindness is that it carries a legal definition, which can be beneficial in terms of tax purposes and benefit purposes for people. So sometimes they can meet criteria in that manner. But typically I address
criteria.
Exactly. Yes. But I typically address the concept from a more humanistic as opposed to a legal aspect.
Right. I'm sure that helps alleviate some of the anxiety around it. But on the flip side, I mean, people are at a crossroads. They're choosing between some version of blindness versus having to do injections, which is a pretty scary idea, a needle in the eye. For months or years, right? So how do you address that? I mean, we often have to face that kind of questioning or anxiety from our patients. Yeah. So it's really about trying to limit the blurriness is the way I like to think of it or talk about it with people. And as you're alluding to, this is a huge concept. And what I find is that I stage people into the discussion. So I have a very standard discussion day 1, a very standard discussion visit 2. And then as we get to visit 3, the discussion is standard with a little zigs and zags based on what they need, and it expands over time. So usually as we progress, people are more able to process what's going on. They've had some time to think and talk with loved ones. They're more able to accept the disease that they've got, and they're more able to formulate the questions that are going to affect them day to day. So you were just saying, how do we deal with that chronicity? And as we get a few visits in, people begin to understand that AMD is a chronic disease with no cure, but treatment to control the pathology and slow the loss. And they understand that I'm there as an advisor, an assistant to help them navigate that path, and not just their doctor that's technically doing a treatment. And no, that's great. And often people want to know if there are any other treatments that are coming up, especially when they get to these more advanced stages or the treatments are not working so well. Is there anything on the horizon that you think, again, I guess, especially when it comes to advanced dry AMD, where our treatment options are more limited, that might be interesting in the future? Yeah, I mean, obviously, it's such a huge area of discussion. And sometimes I find the low-tech solutions are really the things patients need the most. So sometimes what they really need is a better magnifier, a brighter light, more contrast enhancement, moving away from reading on paper to reading on an electronic device. And that allows people to magnify things differently.
As we move on beyond some of those technological aspects and begin to think about medicine, there's all sorts of different things happening aside from the injectables that we've already spoken about. There's different ways to deliver medications to the eye. It's still an injection-based technique, but instead of putting it into the eye, you put it around the middle coat of the eye. That seems to provide a longer duration. We call that suprachoroidal injections. There's as well different technologies to deliver long-term dosing through controlled viral vectors that provide sustained release through manipulation of the cells inside of the eye to try and provide the good chemicals to fight the bad chemicals inside of the eye. And that can be either a surgically implanted device or actually a surgery where actually injecting viral vectors that insert new DNA products into the cells. Quite sophisticated and fascinating stuff.
Yeah.
There are different surgical approaches through telescopic vision that people have tried. Not really my favorite right now. I haven't been overwhelmed, but you find a case now and then that fits a niche like that. As we're looking down with wet AMD, we've tried different surgical techniques to kind of shift and move the retina to get better tissue to better spots. Hasn't really panned out so great, as you're well aware. And there's been trials in the past about these bionic eyes, basically implanting a microchip into the eye itself so that it can provide a computer-based vision for people. That technology is completely fascinating and probably will have huge applications, but way down the line and not a tomorrow type of thing. But I really like to think of it, I suppose, more as low tech, medium tech, and then what's coming down the horizon. I think the final thing, if you don't mind me just talking about it a little bit, is there's a lot of buzz, particularly these days on social media, about different light-based treatments.
Red light therapy.
Different wavelengths, even with the concept of what we've done for muscles and muscle injury and tissue regeneration in the past. Some of it's quite interesting. I find right now it's making a bigger buzz on social media than it is in the scientific literature.
Absolutely.
And I think there's probably some great potential out there, but it's just a little too soon for us to be recommending it to patients until we get a few more good quality studies under our belt. And who knows, maybe those studies are going to come out tomorrow. And by the time the podcast is up, it's going to be greatest thing. Maybe it'll be 5 years and maybe it'll be never, but certainly some interesting action happening.
Yeah. I mean, the commercial interest is definitely there, but I think the science as of now is kind of lacking as some of these light therapy things that are out there. And I think it's important for folks to understand what's real science versus what's social media buzz, because there's a lot of information out there on the internet, on social media. But I really like the fact that you alluded to these low vision aids that we kind of maybe discount a little bit. But in reality, in terms of day-to-day function for people with advanced disease, they can actually make a big difference, right? And they're available at sometimes through, in Canada, there's some publicly funded clinics, right? And elsewhere without costing a huge amount of money, but it can actually help people get through their daily lives, right?
Yeah. And what I even tell people is to try and get really specific with their vision requests. Because for the most part, patients say, completely understandably, they say, I want to see better. Unfortunately, because we don't have a cure, we need to actually help on a task-specific goal. So I want to see better to read my Tom Clancy novel. That's a task that I can help with. Maybe I need to take the book away from paper and computerize it. Maybe we need to do it audio so that they're stimulated in a different way. I want to see the telephone to call my family members. Okay, well, maybe we need to get a larger font telephone with bigger numbers to be able to look at it differently. Some things like in the kitchen, trouble with food chopping, because the contrast on a dark countertop with a dark vegetable makes it very hard for people. So sometimes just getting a light colored cutting board for dark foods and a dark colored cutting board for light foods will make all the difference. And my point is really the more
increasing the light in the kitchen, right?
Yes. Yeah. But the more task specific we can be, the easier it is to find some solution for people.
Perfect. All right. So I guess the last question that comes up fairly often when I discuss these treatments with people, especially we're talking about injections for wet AMD, is how long is it going to go on for? Right? I mean, that's something that people, even the ones that are accepting of the treatment, at some point they kind of get fatigued with the frequent visits and the frequent injections. So they want to know what's the end of all this. So what do you say to those patients who ask you that question?
Right. So obviously the discussion is built up over a series of visits, but if we just encapsulate it in kind of one snapshot, it's that AMD is a chronic disease and it requires chronic treatment to help slow the progression of disease. And if I had a pill that they could take every day forever, they'd take a pill every day. But I don't have a pill that they can take every day. And instead, what I've got is a shot, but they need that shot at some frequency, once a month, once every 3 months, whatever it is. And that's the way we control their disease. I might need to repeat that discussion a couple of times with folks, but I find when they've had some time to process it that they can begin to get the concept of chronic disease.
Yeah. And it really is hard to tell when or if you can terminate the treatment, right, at some point.
For sure. There's some literature to indicate that about 10% of patients need a very limited course of injections for wet AMD and then are able to come off of treatments for a very extended period of time, years or forever.
Mm-hmm.
But that means 90% of people need treatment lifelong at some frequency to slow progression and maintain what they got.
Okay. All right. So, David, this is a fascinating discussion. I really hope our patients find it as useful as I found it useful. And I hope that we can have you for another discussion at a later time. Thank you so much for your time.
Thank you for having me.